Good morning, respected Swankar sir, Vice Chancellor sir, Pro Vice Chancellor sir, Medical Superintendent sir, and my respected seniors, uh, faculty colleagues, and my dear students. On behalf of Department of Dermatology, I welcome you all in this CCR. Uh, I joined Department of Dermatology, SMS Medical College as a PG student in 1987, leaving Gynae after doing 10 months house job. After 10 months, when I entered that department, I was the only female in that department. Probably that time girls were hesitant to join dermatology because we had to see lot of patients of leprosy and sexually transmitted infections. But with the advent of aesthetic dermatology and dermatosurgery, a lot of students they aspired for the dermatology, and especially girls. But now boys and girls they are equally aspirants for the dermatology. In our department, we have three professors, one associate professor, and three assistant professors with two senior residents, and most of us are female dominated. Then dermatology now has clinical dermatology as well as aesthetic dermatology. In clinical dermatology, we are running specialty clinics in sexually transmitted diseases, psoriasis, Hansen's disease, vesicobullous disease, vitiligo and pigmentary diseases, connective tissue, and autoimmune diseases. In aesthetic dermatology, we are working on lasers for hair removal, pigment removal, and chemical peels we are doing regularly, dermal fillers, thread lift, and platelet rich plasma therapy. And we are also having dermatosurgery in our department. We are doing continuous research and publishing the papers. Last year we published 14 articles, and our students also uh, presented papers and posters last year, 16 in number. Our faculty has contributed in various chapters in different books also. Then we are conducting regularly the workshops for aesthetics like thread lift workshop, botulinum toxin workshop, chemical peel, hydrofacial, HIFU for the hands-on training of our students. Then we are holding inter-department meetings also with rheumatology, allergy, and ENT department, then medicine department, gynae department, and pathology department regularly. Then our faculty has achieved various honors in different conferences, and even our students have got prizes in various national conferences. Our department is also having going for field visits for various camps and outreach programs, and we are regularly having TV programs and patient education programs. Then this is about the this time what we have in the department, but we have future plans of the department also. We want to have a laser and aesthetic center and start the fellowship in aesthetics and lasers and establish institute of excellence in dermatology, and that we can do with the help of management. So mainly plastic surgeons, but some dermatologists are also doing, but we need special OT for that. We can also do it, but mainly plastic surgeons. This was briefly about the department, and now we'll proceed with the case. And for this, I would invite Dr. Akshit Yadav, second year student of our department.
Thank you, ma'am. Good morning to the dignitaries, teachers, dear colleagues. Myself, Dr. Akshit from second year resident from the Department of Dermatology, will be presenting a case of a 36-year-old female with recurrent fever, joint pains, and erythematous skin lesions. So, coming to the case presentation, a 36-year-old homemaker, resident of Churu, was referred from the Department of Rheumatology for evaluation of the skin lesions. She presented with fever, joint pain, and multiple red raised lesions over face and legs, which occurred for 2.5 years on and off. Now, history of presenting illness. The patient was apparently alright 2.5 years back when she developed complaints of sudden onset of intermittent episodes of moderate to low grade fever, usually in the evening, on and off, since 2.5 years. Fever was not associated with chills or rigors. It lasted for 3 to 4 days and recurring every 3 to 4 months. Sometimes the fever resolved spontaneously or after taking medication. She also experienced acute onset symmetrical dull aching polyarthralgia involving bilateral wrist, knees and ankles. The joints were not swollen, not associated with morning stiffness and lasted for 5 to 6 days. The pain eased with rest and did not interfere with the daily activity. And she was completely normal without in between the episodes, and there was no deformity, and notably the joint pain coincided with the febrile episodes. Now, skin lesions. She also had a sudden onset of coin-sized red raised lesions over bilateral face and bilateral lower limbs. The lesions were painful but not pruritic and lasted for 10 to 15 days. They used to heal spontaneously with pigmentation but without any scarring, and they also evolved in crops in association with fever and joint pain. So, after history, the points we looked for, there was no history of sore throat, chronic cough, dyspnea on exertion, significant weight loss, night sweats, chronic diarrhea or constipation or melena, and there was no slippage of footwear, difficulty in holding objects, nasal stuffiness and epistaxis. Also, there was no history of photosensitivity, oral or genital ulcers, grittiness in eyes or dryness of mouth, high risk sexual behavior or blood transfusion, or any drug intake prior to the onset of lesion. Now, continuing with the history, there was no relevant past or family history, and she was vegetarian, non-smoker, non-alcoholic, and bladder, bowel, and sleep habits were normal. Menstrual and obstetric history. The patient reported regular menstrual cycle with no associated complaints, and her last menstrual period was 12 days ago. Obstetric history revealed gravida 3, para 3, with all 3 children were term deliveries by normal vaginal route, and there was no history of abortion. And socioeconomically, she belonged to upper middle class. And in the treatment history, in the past 2.5 years, she visited various doctors, but was given only symptomatic treatment. And in the visit to our hospital, she was being treated as urticaria and given tablet prednisolone, for which she was taking for 3 to 4 days. So, now putting for question to the audience, given this clinical picture of recurrent episodes of fever, joint pain and painful erythematous lesion, what possibilities would you consider? Based on history, these were the possible causes. They can be either infective, which can be due to bacterial causes like tuberculosis, leprosy or syphilis, viral causes and vasculitic causes, drug reaction, inflammatory causes which consist of sarcoidosis, erythema nodosum, Sweet syndrome, Still's disease, Behçet's disease, ulcerative colitis and Crohn's disease. And in autoimmune causes, they can be Sjogren's syndrome or systemic lupus erythematosus. In malignancies, they can either be solid organ tumor or a hematolymphoid tumor. As involvement of some majorly large joints, wrist, ankle and knees and ankles, and there was no deformity, sir, for 2.5 years.
They have mentioned only Sjogren's syndrome and SLE, not mentioning rheumatoid arthritis.
As the patient did not give any history of drug intake prior to the onset of lesion, drug reaction seemed unlikely. And also, ulcerative colitis and Crohn's disease were unlikely as there was no history of abdominal pain, recurrent diarrhea or constipation. After that, these possibilities were left and we proceeded to examine the patient. Coming to general physical examination, the patient was conscious, cooperative, well oriented. She was adequately built, afebrile, with normal vitals and no pallor, cyanosis, clubbing, icterus, edema or lymphadenopathy. And coming to systemic examination revealed normal findings. And now proceeding to the mucocutaneous examination, there were multiple well-defined erythematous nodules and plaques of size 3 millimeter to 5 centimeter, present discretely and asymmetrically over face, lower extremities. And on palpation, the lesions were tender, indurated, and the temperature was raised. As these lesions were tender, evanescent nodules, morphologically these lesions resemble erythema nodosum. Now coming to mucosa, scalp, palm soles, hair and nails were spared. Now coming to sensory examination, it revealed loss of thermal sensation, hot and cold, over the right palm, while fine and crude touch sensation were preserved in all limbs. Motor examination showed normal muscle power and tone with intact deep tendon reflexes. And on peripheral nerve examination, the right ulnar nerve was found to be thickened and mildly tender. The nerve was thicker on the contralateral side, consistent with grade 1 thickening, and the tenderness was graded as mild, as the patient reported pain only when specifically asked for it. So, a quick recap of the case. A 36-year-old female with 2.5-year history of recurrent episodes of fever, pain in multiple joints, and erythema nodosum-like lesions, along with loss of temperature sensation over right palm, thickened and mildly tender right ulnar nerve. So, based on the examination finding, we had a high index of suspicion for leprosy, specifically erythema nodosum leprosum. So, to confirm and rule out other possibilities, we wanted to investigate the patient further. So, coming to some bedside tests we did a slit skin smear. The smears were prepared from the earlobes and nodules, and the smear was stained with Xeelensen staining, and on examination there was no acid-fast bacilli seen. And pathology test was also done, which is done for neutrophilic dermatosis, and it was also negative. Sir, it is a test, sir, non-specific skin hyperreactivity test, sir. It is done for neutrophilic dermatosis. In this, sir, we do on the volar aspect of the forearm, we injure the patient. We inject the patient with normal saline at a 35-degree angle intradermally on with 18-gauge needle, and we follow up the patient after 72 hours to see if there is any ulceration present or not. So Montauk's test, we inject, sir, PPD, sir, purified protein. Procedure, sir, we inject three sites, sir, on the forearm in pathology. And sir, Montauk's is done with a 28 or a 26 gauge needle, sir. It is done with a 18 gauge needle.
So, what is the interpretation? If an ulcer forms, what does it mean? And sir, if an ulcer doesn't form, what does it mean? Sir,
if the ulcer forms, it suggests, sir, there is neutrophilic dermatosis, sir. It suggests that there is a underlying pathology. Neutrophils are causing reaction in the skin, sir.
And if it doesn't form, that means that there are no neutrophils, or there are...
No, sir, there is not excess of neutrophils. Sir, neutrophilic dermatosis, there is excess, more production of neutrophils, sir. That's why it causes this disease, sir.
So, injecting somebody's forearm with a 16-gauge needle, as you said.
18 gauge.
18 gauge.
Yes.
That must be an uncomfortable procedure.
Yes.
Just do a CBC and PBF and look at the neutrophils.
Sir, it is a criteria, sir. For Behçet's disease, sir, it is in the criteria if pathology test is positive or not.
If a peripheral nerve is palpable, the only possible diagnosis is leprosy? Nothing else?
No, sir. We had a suspicion for leprosy, sir, because, sir, with the fever and erythematous...
That's fine. What else?
Sir, in polyarthritis nodosa also, sir, there is neuropathy, sir. Now, coming to the investigations, routine investigations, CBC was grossly normal with raised ESR. Renal and liver function tests were within normal limits. Urine routine examination was unremarkable, and serology testing for HIV, HBsAg, anti-HCV were negative, and VDRL and TPHA were also negative. Montauk's test was negative. Imaging studies including chest X-ray and ultrasound of the abdomen were normal. Urine autoimmune screening including ANA profile and rheumatoid factor were negative, and serum angiotensin converting enzyme levels were significantly elevated at 84 units per liter, and C3 C4 complements were within normal limits. So after investigation, coming back to our possibilities, as there was no history of any chronic cough, with a negative Montauk's test and normal chest X-ray, tuberculosis seemed unlikely. VDRL TPHA were also negative, making syphilitic cause unlikely. Viral markers were negative, making viral causes also unlikely. Now, among inflammatory conditions, Still's disease was also ruled out based on there was no lymphadenopathy, splenomegaly, and normal routine investigations. Behçet's disease was also excluded on the history of no oral or genital ulcers, routine investigations, and a negative pathology test. Autoimmune conditions were unlikely as there was no history of photosensitivity, dryness of mouth, or giddiness in eyes, and a negative ANA profile. Malignancy, including both solid organ and hematolymphoid tumors, were considered unlikely based on history, normal investigations, and imaging findings. So after this, we were left with these possibilities, and to further work up, to aid in the definitive diagnosis, a 3 mm punch biopsy was performed from the erythematous lesion over left leg. The tissue sample was obtained under aseptic precaution and subsequently submitted for histopathological examination. Now, I would like to invite Dr. Rhea from the Department of Pathology to take the case further.
Good morning, everyone. Thank you, Dr. Akshit. Good morning, everyone. My name is Dr. Rhea Trivedi, and I will be discussing about the histopathological examination. First, I would like to discuss about the normal histology of the skin. This is a 4x magnification image of a full thickness skin biopsy showing layers of the skin. First and the outermost is epidermis. Beneath it is the dermis, which is divided into papillary dermis and reticular dermis, and the deepest layer is the subcutaneous tissue containing lobules of adipocytes separated by fibrous septa and blood vessels. Now coming back to our case, we received a single skin covered soft tissue piece measuring 0.2 into 0.3 into 0.2 centimeter. On microscopic examination under 4x magnification of a full thickness skin biopsy, we can see perivascular inflammatory infiltrate in the dermis extending into the subcutaneous fat, which is known as paniculitis. Under 10x magnification, we can see inflammatory infiltrate confined predominantly to the septa in between the subcutaneous fat. This inflammatory infiltrate is composed predominantly of neutrophils, epithelioid histiocytes, virtual cells, and lymphocytes with nuclear dust. Under 40x magnification, we can see virtual cells, which are large foamy macrophages distinguished by their abundant granular and foamy cytoplasm due to numerous bacilli. These are 40x magnification images showing vasculitis, in which we can see vessel wall showing endothelial swelling and infiltration of inflammatory cells within and around the vessel wall. These are microscopic images of tissue sections stained with Phyt Farraco stain, which is useful in identifying Mycobacterium leprae in tissue sections. Here, under 40x magnification, we can see virtual cells which are distributed diffusely in the dermis and within the widened subcutaneous septa. And under oil immersion view, we can see numerous lepra bacilli appearing as reddish pink rod-shaped structures within the cytoplasm of foamy macrophages set against a blue background. These are the differentials. Each condition is compared based on their key microscopic features such as presence of paniculitis, foamy macrophages, neutrophilic infiltrate, granulomas, vasculitis, and presence of acid-fast bacilli on staining. Out of the listed differentials, foamy macrophages, which are also known as virtual cell, are seen only in erythema nodosum leprosum, and further acid-fast bacilli positivity on Phyt stain favors towards the diagnosis of erythema nodosum leprosum. So based on the histomorphological features, our final diagnosis is erythema nodosum leprosum. Thank you.
So if you see intracellular acid-fast bacilli, then you don't need to think of anything else, no? Or do you?
Yes, sir.
Even then can you have bacteria visible and have another diagnosis also?
Yes, sir. We can see acid-fast bacilli in Mycobacterium tuberculosis also, but we cannot appreciate it in Phyt Farraco stain because Mycobacterium tuberculosis is a strong acid-fast bacilli and leprosy is a weak, Mycobacterium leprae is weak acid-fast bacilli. That's why. And it is specifically seen in Phyt Farraco stain only. Thank you. And now I would like to call Dr. Akshit to carry forward the discussion further.
Thank you, Dr. Rhea. Now, proceeding with the case, based on the clinical presentation, peripheral nerve finding, and histopathological examination, and exclusion of other systemic and autoimmune causes, the final diagnosis established was Hansen's disease in lepromatous pole in a type 2 reaction, which is erythema nodosum leprosum, not on treatment and without any deformity. As erythema nodosum leprosum occurring as the first clinical manifestation in the patient without prior diagnosis or treatment of leprosy, it is termed as de novo erythema nodosum leprosum. Now, that we have the diagnosis of Hansen's disease, the patient was initiated on the multibacillary multi-drug therapy blister pack. This pack is provided free of cost to the patient by the government under the National Leprosy Eradication Program, and our institute has a MOU with the government for the same. She was classified as multibacillary type, and this pack, which is the multibacillary pack, is provided, which consists of day 1 tablets, which is demarcated by these lines. It contains 2 capsules, 300 mg each of rifampicin, 3 tablets of clofazimine 100 mg, and a tablet of dapsone, which is 100 mg. These are given on day 1 under supervision, and rest of the pack is given to the patient, which contains 50 mg of clofazimine and 100 mg of dapsone. The rest, here we can see the back side of the pack, we can see the day 1 tablets, and the rest of the pack is given and the continuation of the patient for adherence. As the patient was also in type 2 reaction, the patient was managed on tablet prednisolone 30 mg once daily, tablet clofazimine at a higher dose at 100 mg 3 times a day, tablet etoricoxib, and supplementation was also given. So, coming to the clinical course of the patient at week 2, the patient showed significant clinical improvement. The skin lesions healed. There was no further episodes of fever, and joint pain has subsided. Week 4, the adjustments were made based on symptom improvement. Prednisolone was tapered to 220 mg. Clofazimine was reduced to 100 mg twice daily, and there was improvement in the neuritis. The patient remained stable at week 8. No new complaints were reported, and steroid was tapered at a bi-weekly interval. At week 12, the steroid was stopped and neuritis had subsided, and the clofazimine was further reduced to 100 mg once daily. And also, for monitoring, we did CBC, liver function test, and RBS twice weekly, along with the vital monitoring. So,
how did you recognize that neuritis subsidized?
Sir, by palpation, sir. In palpation, sir, when we palpated the nerve, she was when asked, she was complaining in the beginning. When we again palpated and asked for if it is having pain, it was not painful, sir. Sensation, it was lost, sir. It did not recover. So these were the photos of the patient at the baseline at 3 months follow-up, and she is still continuing on MDT pack at 9 months follow-up of the patient. Now, I would like to invite Dr. Avani to take the discussion further.
Thank you, Dr. Akshit. Good morning, everyone. I am Dr. Avani Verma, second year resident from Department of Dermatology, and today I will be talking about a series of 4 cases of Hansen's which came to our OPD in a short span of 6 months, and these cases had atypical presentations, and hence the title Unmasking the Mist. So our first case was a 38-year-old male who presented with the chief complaints of multiple non-healing ulcerated plaques over both extremities since last 6 months. He was being treated as a case of non-healing ulcer in periphery but got no relief. On examination, we noticed loss of temperature sensation in the affected areas and also enlarged greater auricular and right ulnar nerve, which pointed us to further investigate in the lines of Hansen's. We then took a skin biopsy from these lesions, and which came out to be consistent with Hansen's disease, Erythematous leprosy type. So we gave MDT-MB therapy, and here is a comparative picture of significant improvement after 4 months of therapy. Our second case is a case of a 26-year-old female who came in with widespread erythematous crusted plaques involving whole body since last 10 days. It was associated with fever and tenderness. It was being treated what was thought to be infected necrotic ulcers. However, a clinical examination revealed loss of fine touch and temperature sensations, a red flag which pointed for further evaluation. A skin biopsy was then again taken, and it confirmed to be the diagnosis of erythema nodosum necroticans, a lepra reaction, which is often mistaken for infectious or allergic conditions. The patient was given supportive care for lepra reaction and started on MDT-MB therapy. And these are the baseline pictures which showed improvement after 5 months of therapy. The third case is a case of a 61-year-old male who presented to us with multiple erythematous plaques over his face, trunk and lips for 10 days. He was being treated as urticaria given the short history, but on examination there were presence of infiltrating plaques on face, and there was also loss of sensations, which came in consistent with the diagnosis of Hansen's disease Erythematous leprosy type. Here is the before and after picture with significant clinical improvement. The case 4, our final case, was a 30-year-old male who came to us with a short history of 7 to 8 days with history of multiple erythematous plaques present on face and ear. He also had a recent history of fever for which he received treatment but temporarily improved, but the skin lesions recurred. This case was being managed as a case of insect bite hypersensitivity. We planned for a skin biopsy looking at the clinical presentation and revealed the diagnosis of erythema nodosum leprosum. Here is a 4 months post-treatment follow-up pictures showing good resolution where the plaques on face and infiltration in the ear had subsided. To support our case series, I'd like to highlight a few published case reports that shows how leprosy continues to be misdiagnosed, largely because it can mimic a wide range of other conditions like rheumatoid arthritis, cutaneous tuberculosis. And why do these cases matter? Hansen's disease is still prevalent, but slips under the radar. Because of its diverse presentations, it continues to be misdiagnosed. The consequences of missing it are significant. Nerve damage, deformity, disability and the associated stigma. Our aim through these series is simple: to emphasize on early diagnosis and treatment so that deformities can be prevented, and in this era of autoimmune diseases, leprosy can easily masquerade, so one must keep a high index of suspicion. Now, I would like to invite Dr. Priyanshi Tripathi to discuss the review of literature.
Thank you, Dr. Avani. Good morning, everyone. After the intriguing case series of leprosy, let us now understand what leprosy is and its clinical spectrum. Leprosy, also known as Hansen's disease, is a chronic infectious disease caused by Mycobacterium leprae. It primarily affects the skin, peripheral nerve, mucosa of upper respiratory tract and eyes. It has a very long incubation period of around 2 to 20 years, and the major mode of transmission remains the droplet infection. Leprosy presents along a spectrum. So before we understand erythema nodosum leprosum, let us briefly understand its clinical spectrum and its 2 reaction patterns. The Ridley-Joplin classification of leprosy is based on strength of patient's immune response to Mycobacterium leprae. At one end lies the tuberculoid pole, in which patient mounts a strong immune response to Mycobacterium leprae. It has low bacterial load and the smears are usually negative, and it clinically presents as single to few well-defined hypopigmented anesthetic patches. While at the other end lies the lepromatous pole, in which body has a poor immunity to the bacilli. The bacillary loads are very high and the smears are strongly positive. It clinically presents as widespread symmetrical skin lesion and widespread infiltration. Facial involvement is also commonly seen, leading to the characteristic leonine facies. Reactions are acute inflammatory episodes that occur during the chronic course of the disease. Type 1 reaction, also known as the reversal reactions, occurs in the borderline forms. Signs: it clinically presents as inflammation in existing skin lesions, nerve pain and swelling. And the type 2 reaction occurs in the multibacillary forms, that is borderline lepromatous and lepromatous leprosy. It clinically presents as painful erythematous nodules, fever and with systemic complaints such as arthralgia or arthritis or orchitis. In lepromatous leprosy and type 2 reaction can also present with systemic involvement and various deformities. A 10-year retrospective study was also conducted in our department focusing on the clinical patterns and the associated deformities and deformities. The study showed that there is significant burden of underlying deformities that needs the that underlines the ongoing need of early detection, timely treatment, and disability prevention strategies in leprosy. Now, I would like to invite Dr. Shivangi from Department of Community Medicine to discuss further.
Thank you, Dr. Priyanshi. Good morning, everyone. Myself, Dr. Shivangi, second year resident from the Department of Community Medicine. Now I'm going to brief about the epidemiology of leprosy and National Leprosy Eradication Program. Starting over with the global progress, over the past 2 decades, the world has made a remarkable stride in the fight against leprosy. Leprosy prevalence has been reduced by 90%, marking a significant public health achievement. Since 1985, the prevalence rate has seen a dramatic decline from 21.1 per 10,000 population to just 0.17 per 10,000 by 2020. Similarly, the global burden of leprosy has dropped sharply, falling from 5.2 million cases in 1985 to 1.65 lakh cases at the close of 2020. In 2022, new case detection rate was 0.22 per 10,000 population, with slow downward trend over the past decade. There is an increase in cases after 2020. Looking in 2023, every one of the 6 WHO regions have reported new cases, where nearly 3/4, that is 71.9%, were alone found in Southeast Asia region. Between 2014 and 2020, global new case detection rate has decreased. The pandemic in 2020 caused a big setback, reducing the number of detected cases. However, the detection of new cases are going up again. This is a map diagram showing leprosy case distribution in various districts of India. In Rajasthan, western districts have sporadic distribution. Jaipur, Jodhpur, Kota, Jhalawar, Udaipur and Siroi have moderate endemic leprosy case distribution, while the rest of the state is low endemic. Now coming on to the National Leprosy Eradication Program, recently on January 30, 2023, the Indian government launched the National Strategic Plan and Roadmap for Leprosy 2023-2027 to achieve zero leprosy transmission by 2027, 3 years before the Sustainable Development Goal target. The National Strategic Plan for 2023-2027 is based on 4 pillars, starting with accelerated case finding and quality services for all the patients. Second, maintaining sustained momentum through effective surveillance. Third, continuing efforts at implementing targeted interventions to interrupt transmission. And lastly, ending with the goal of zero leprosy by 2027. The theme of our Spurs Leprosy Awareness Campaign 2025-2026 is "Together let us raise the awareness, dispel misconceptions and ensure no one affected by leprosy is left behind." Sapna is the awareness campaign mascot. Lastly, India's goals for 2027 are ambitious yet achievable, aiming for zero transmission, zero grade 2 disability and zero discrimination, marking a significant step towards a leprosy-free and inclusive society. Lastly, India's sprint to stop leprosy by 2027 under the National Strategic Plan is leading the world towards WHO vision towards zero leprosy by 2030. Now I invite Dr. Priyanshi to continue further.
Thank you, Dr. Shivangi. Coming back to our earlier case, that is the de novo presentation of erythema nodosum leprosum. The exact incidence is unknown, but only 4 to 5 Indian and less than 10 case reports have been published globally since it's a rare presentation. What makes this presentation atypical is that it lacks classical skin lesions of leprosy. Patient presents with systemic symptoms like fever, joint pain and nodules. It occurs in patient with no prior leprosy diagnosis, hence it is often misdiagnosed, and as typically erythema nodosum leprosum arises in patient already diagnosed with leprosy and undergoing treatment. So our take home message is that leprosy is a great mimicker. It can present from a single anesthetic patch to multiple erythematous plaques and nodules to severe deformities and systemic involvement. Hence it is often misdiagnosed, leading to the delay in diagnosis and treatment, which could also be the reason of the recent increased transmission and resurgence. Stigma associated with leprosy
also remains a major barrier, as fear and misinformation prevent people from seeking timely care. So education and awareness programs play a vital role. We would like to end with a glimpse of our institute's initiative on World Leprosy Day. This year's theme was Unite, Act and Eliminate. We organized awareness activities aimed at educating the public, busting myths and reducing stigma associated with leprosy. The NLEP logo you see here stands for Protection, Partnership and Progress, reminding us that elimination isn't just a medical goal but a social one too. I would like to extend my heartfelt thanks to management of Mahatma Gandhi University, Department of Pathology, Department of Community Medicine, CCR Review Committee and nursing staff, and most importantly the patient and their family. Thank you so much.